So I will over the platform to Dr. Desar for the presentations. I think our screen is visible. Gunesh,
Yes,
screen?
yes, yes.
Okay, okay.
Just next on it.
Yes, next only. If you'll not see the properly, I just wanted to keep him so that he can see some participant after the planner.
Yeah.
Or you can keep it like that, like before only, just keep it. Just one.
I think that upstairs.
Not this two line only.
Up
Yeah,
only,
two
yeah.
only. Two only. Yes. Wait, it's a. Okay, it's okay. Beside those. It's okay. In between.
Okay. Good afternoon, everyone. Thank you, Nanika, for this time. So today we'll be starting, as she have correctly mentioned, give me introductions. Okay, I've been here for almost 3 years now, to be specific. Almost 3 years in Nigrib. So I've been working as a senior resident here. I hope I'm audible. I don't have to raise my voice.
Yes, you are audible.
Okay, thank you so much. Today our topic is high flow nasal cannula. Okay, so we will be. I have to press it. Okay. Okay. This is the one and the other one. There were two, no? Just a second. Sorry for that. So our topic is high flow nasal cannula. So we will be dealing only specifically on this, how it is being used. We will be talking more on a practical basis and then where we can use it and in emergency situation or what type of patient we can use it, how to choose what patients for what we can use it. So high flow nasal cannula, this is how it does it, how it work. This is how the instrument you be, and then so here we can see, you can see my pointer. Can they see my pointer? Okay. You see this. This is the blender, we call it here in high flow nasal cannula. One thing you should know that it has the component which it has oxygen and humidified air. So in here we have this blender where once the oxygen will come, and then another one they didn't show here exactly, where we have the medical air also it come. Okay, here we blend according to what FiO2, how much we want to titrate or to start giving our oxygen level to the patient. So accordingly, maybe it can be 40%, 50%, 60%, depend on the severity of hypoxia of the child. Or maybe sometime the child does not require oxygen, but just to overcome the obstruction which is present in the upper airway, or maybe just for the inflation of the lungs, so we don't require that. So we use this blender so that we can give oxygen accordingly. For example, like maybe if we don't require too much, we can start with 30% and titrate it accordingly and taper it down. And then you will see here, this is the humidified. So high flow nasal cannula in children, we always use humidified one. Because why? Humidified, it prevents us, we'll be talking in detail in the separate slide, because humidified help us in making our air humidified, because so that it will prevent crusting. It prevent crusting on the child nasal cavity or maybe pharynx. Okay, so it will reduce the irritability toward the child. Okay, so that's why we always use humidified. humidifier, this one. Okay, and then the distilled water we prefer to put here. And then it's connected. This is due to connector, which will, this is the nasal part to the patient, nasal cannula toward the patient. So how to choose this one also, we will be talking accordingly when we go to reach to the slide. Okay. So I hope some of you has already been working with this type of instrument, this type of in your ICU or maybe in your critical care or in your emergency casualty area. Okay. So what are the factors determining to use the method, whether we will use a high flow nasal cannula or NIV? Okay. So in high flow nasal cannula, this is, you see there are different way of giving oxygen therapy. First of all, we give oxygen therapy can be maybe as simple as a nasal prong, okay? Or maybe as simple as mask, face mask, or it can be by NRM. There are different type of oxygen therapy we can give to the patient. And then what is, then if the patient fail with all this simple oxygen therapy, then we will height up, then we can go to high flow nasal cannula, because why? There is a high flow, there is a flow, there is a pressure in it, which cause the with pressure, which make the air to reach the lungs. So the gas exchange will be there. Now, if our high flow is not performing well, we can go into non-invasive ventilation. So non-invasive ventilation is another way of giving. Here the pressure is much more. Okay, and then if the patient is much more, if it's so much irritability, or maybe the patient is fighting with NIV, then our another option are not maintaining in NIV, then we will go for invasive ventilation, that is intubation. So that is how we will titrate or goes up, or even though if we have to extubate the patient, we will go in the same way. We'll extubate the patient from invasive procedure, invasive ventilation like intubation, we'll go down to NIV. Or maybe we can skip NIV, depend on how we anticipate the child. For example, if the child has been prolongedly intubated due to bad lung, ARDS, bad lung. So instead of going directly to oxygen therapy or high flow nasal cannula, we know that the high chance that we will be having extubation failure. So to prevent our extubation failure, we will go down with NIV, and then slowly high flow, then to simple oxygen therapy. So what is high flow nasal cannula on NIV? It need a high FiO2 in high flow nasal cannula, so we prefer, that's why we prefer it. There is a humidification is required, okay, and then comfortness, like I told you, it's quite more comfort because there are much less pressure as compared to NIV and others. Okay, and then in NIV it's increased work of breathing, where mean like there are so much distress. The patient, see, since I'm a pediatrician, I'll be talking more about you, I'll be hearing more about child or more about baby, right? So for example, if our patient, our babies, our children is having so much difficulty, I mean, he have to work for breathing. We can see nasal flaring, subcostal retraction, suprasternal retraction, using of accessory muscles and all. So a lot of work of breathing is there. And for example, we did ABG, arterial blood gas, and we find that PCO2 is very high. So and then that means this type of child would require a much more invasive, much more pressure to deliver oxygen. So that's why we choose NIV. And then if you comparatively NIV and invasive ventilation is much more expensive, and then it has its own side effect and own profitable. And then, but in this situation, in case like we have economical issue where we are in two minds whether to intubate or not intubate, so we would, NIV will give us a good time to think or to see, to evaluate our patient. So what are the indications of using high flow nasal cannula? The indication is always obviously in case of respiratory distress. Obviously, a child who doesn't have respiratory distress or who does not require. I mean, you can simply give him simple oxygen therapy. But if distress is there too much, work of breathing is too much, he have labor breathing, and then you can see tachypnea is there, and the patient is also lethargic because he have to spend so much of his energy in the respiratory effort. So those are the conditions where we use high flow nasal cannula. Okay. Now, in case of post-extubation from the mechanical ventilation. So in this situation also, instead of going to simple oxygen therapy, we will use high flow nasal cannula because it has some pressure due to the flow of oxygen. So the work of breathing will be much less as compared to the simple oxygen therapy. Now, for example, a weaning therapy from CPAP or BiPAP. See, CPAP and BiPAP is also another non-invasive ventilation, where in this condition, there, like mentioned before, not too much, there are a lot of much more pressure as compared to high flow nasal cannula. So if our patient is maintaining our saturation in high flow nasal, BiPAP or CPAP, now instead of, FiO2 is quite less, and then work of breathing is very less, and then there is very less tachypnea, retraction is there. But instead of going to simple oxygen therapy, maybe like nasal prong or maybe using of face mask, so it's better if we have an option to use high flow, because this will give us a good time or good weaning for the patient, and our chances of failure of weaning is much more less, instead of going directly to the simple oxygen therapy. Now, another situation is, in case of baby who are apnea in maturity. Apnea is something, apnea of prematurity mean patient who have cessation of breathing. Because why? This baby who are premature, low birth weight, delivered at 8 months, maybe 7 months or 8 months, no, usually less than 8 month babies who delivered like that, and their birth weight is less than 1.8 kg, used to have this apnea, means cessation of breathing with bradycardia. So in this type of situation, how we can use this high flow, because high flow all the time, it keep on giving pressure to the nasal cavity. So this will make our baby awake. Mean in a sense, not waking up, but in a sense, mean making our baby to cause irritation over them, and it will keep on stimulating our baby to breathe. So in that mechanism, in simple way of explanation, it will prevent us from this apnea of prematurity. Now, another one is respiratory support to children with neuromuscular disease. Now, for example, in neuromuscular disease, we have a patient who have, let's say, for example, who have JE or Japanese encephalitis sequelae, or maybe some viral infections, or maybe stroke, or maybe infarct, maybe any of those, which cause centrally some involvement is there, pathology is there within the brain. Now, that is one. Number two, maybe in muscular relating to the nerve is not conducting properly. In case of myasthenia gravis, like where we see the muscle neuromuscular patient cannot breathe properly, even he is conscious oriented, but he cannot breathe because of the neuromuscular activity was affected, in case of myasthenia gravis. Okay, so in this type of situation, why it will help us? Because this one, even the patient can breathe, even though they breathe with slow, with less effort, it will still help our patient to breathe well, because in a situation here, there is a pressure which will push the air inside to reach the lung. Even with the less effort of the patient, it will push the air inside to reach the lung, and then gas exchange, it will help automatically. Now, supposingly, if we don't have enough pressure, like in simple oxygen therapy, the gas do whatever the effort of the child breathe, that's it will reach the child lung. So in that situation, there we have a high chance that the child will have some area of lung collapse, where the air does not reach properly, and then if we do blood gas or PCO2 will be quite high. So in this type of situation, to prevent that, one of the simple way of this less expensive, non-invasive procedure, much more comfort for the patient, economically also easy, affordable for the patient, attendant for the patient. So we will use high flow nasal cannula. I hope you guys can follow and audible as well. Hello.
Yes, audible now.
Okay. So when to use? See, the emergency situation always come, either the patient came from ambulance receiving in the casualty, which is in distress, or maybe a patient who were extubated in our extubated in our ICU, or maybe the patient who is going to deteriorate. Okay, now how to recognize this type of patient? So there is a patient who is distressed, maybe dyspnea, there's hypoxemia is there, mean difficulty in breathing is there, and desaturation is there. Mean walk of breathing is so the patient has to walk for his breathing. Okay, and then also when we check the saturation of the child, that the saturation is not maintaining. Maintaining saturation as well, like okay, fine, in summer for us is quite okay, but during winter time, so don't get fooled by the weather, because cold environment, so the hand might be get cold, and then you measure because there's not much circulation because of the cold, then you think okay, fine, hypoxemia is there. Walk of breathing is that you think that the child is having tachypnea, but it's not actually, because the child is having something else, like for example, maybe the child is having high grade of fever, or maybe having CNS. So we have to differentiate all this. Not it's related to the respiratory problem and the hypoxemia. I mean the desaturation, the less saturation of the patient also. It's not due to the cold periphery or cold extremity. It's because of the related to the respiratory problem only. So those type of the patient we should recognize first, and we have to rule out when and whom to use. Because in case of situation of a child who's having CNS problem, you don't have to give high flow nasal cannula. You have to, because the GCS is poor, because they will have, in case of raised intracranial pressure, you will see that the child is breathing fast, breathing fast. But if you check a saturation will be fluctuating, especially for those type of children who have post seizure, who have post abnormal body movement, post convulsion. So the saturation also will drop down. So those type of situation, you will think that okay, he might be having respiratory distress and he have hypoxemia, so I'll give him high flow nasal cannula. Those type of child he doesn't need. They just need a simple oxygen therapy. It'll be fine. Okay. And then we'll go to the next point. Airway issue or a mild hypoxemia who requires sedation for a minor procedure. Now, for example, for us, like what we used to regularly do in our department, in our ward, in our ICU, now we have to do, let's say, lumbar puncture, or we have to do ICD insertion, or we have to do bone marrow. So those type of, if we have a facility, it's better to do. It's better to give a oxygen therapy by high flow nasal cannula, especially for those child who already have a little bit of lungs problem. So it's better for us to give high flow nasal cannula, because why? During sedation, the child will have the breathing effort will be much less. So if we have the high flow nasal cannula, it will have with the help of a pressure, air delivery toward the lungs, it will be much better as compared to the simple oxygen therapy. All right, this will help us in preventing the chances of intubation to the child. Mild respiratory distress who does not need intubation. Okay, so and then who might be not even needed NIV, but do need a bit of respiratory support. Now, for example, a child have tachypnea, who have tachypnea come to you. Tachypnea is there, and then mild subcostal retraction is there. Okay, nasal flaring is there. With simple oxygen therapy, you check your saturation is around 98 to 99. So hypoxemia it's covered up by the simple oxygen therapy. But if you see at the child, but the walk of breathing the effort of he put on the breathing is there. Mean he have that. Instead of giving this only simple oxygen therapy for this type of candidate, if we use high flow nasal cannula, it will have a good chance for us, good outcome for us to prevent the child from NIV or the need of NIV or the need of intubation. And that also all depend on whether availability is also one of the issue. So if we have available, so in all this distress patient, we will preferably use the high flow nasal cannula. And because why? Like I mentioned, this one, it will prevent us. A lot of situation has happened where, child came in respiratory problem. So what we do is we give it nasal prong, not maintaining. Give with NRM, maintaining saturation, but walk of breathing is high. So these are the candidates typically you will see in the ward or in casualty or in where you will better prefer to use this high flow nasal cannula. Okay, because it will help us in preventing the chances of intubation to the child, invasive procedure. Now, what are the contraindications where we can use high flow nasal cannula and where, okay. So the absolute mean, obviously here in this situation, you should not use it at all. Okay. Known or a suspect case of skull base fracture. Okay. And CSF leak. Now, for example, how we will know that we will suspect a skull base fracture, or obviously if it is a known, then it's fine, it's known. And how we will suspect if the patient came in our casualty. So how we will suspect mean, especially, so one of the simple win, these are mostly either fall from height or RTA, okay, and then being hit from the side walls. And another one is that is as the complaint. And then another one is you will see that the ear bleed is there. Ear bleed with the with clear water type, which is present, blood with clear water type. In another way, we call it target sign. If that type is there, where you see bleeding from the ear is there, so I suspect that this child is having skull base fracture, okay, or maybe leaking from the nasal cavity, blood mixed with clear fluid, okay. So in those type of situation, we don't use because of the pressure which it has. It can cause us the air can reach our brain because of the pressure which it contains. So much more pressure will go in and then it will reach the brain, okay. And then in case of situation of significant pneumothorax which has not been treated with chest tube. Now see, in pneumothorax we have this, especially this tension, like in case of tension pneumothorax. Supposingly tension pneumothorax, what happened is in tension pneumothorax, in case of this pneumothorax, significant mean very high, big, severe pneumothorax, what happened is the air is being trapped between the chest wall and the long parenchyma. What happened is the air come through our breathe, and then it leak to the pericardial, to the pleural cavity. Now that air is trapped there. It cannot goes back. It's like a one-way valve. It just go in. Now that is in hand of the child normal breathing. So normal breathing, again, the air is going to the pleural cavity. Now, supposingly, if we use high flow nasal cannula, again in this situation, made with pressure, again, it will be much more pressure. It will reach the lung, and then this pneumothorax will keep on increasing. So the increasing pneumothorax, it will cause collapse of the other lung, and then this child can go to hypoxia and can cause cardiac arrest. Okay. So in this situation also, so when to use it? After, we can use it only after we put chest tube, intercostal drainage. Okay. So before, if you're suspecting pneumothorax, and then before, if the child is having distress and having whatever, without putting chest tube, so we will not use high flow nasal cannula. Okay. And then in another situation is complete nasal obstruction. Obviously, if your nasal, we are using high flow nasal cannula from the word itself, nasal cannula. If obstruction is there, like in case of a neonate, like gonal atresia, or maybe in case of adult who have hypertrophy, significantly hypertrophied turbinate. So in this type of situation, it will not help. All our pressure, all our oxygen will get blocked there, and it will not reach the child lungs. Okay. Now in a situation, another situation is active epistaxis or recent FES, mean any functional endoscopic sinus surgery. Because why? Again, it came to the word pressure. This pressure, this high flow, and then in active nasal cavity, because this nasal cavity, it has that pointing nasal, no, that prong has nasal prong has that pointing. So that one, if it is having active nasal epistaxis, again you'll keep on poking that area. So chances for our child to bleed again. And again, if in case of post-surgery, endoscopic sinus surgery, because they just finished surgery, and then we keep, if we keep high flow nasal cannula for them, the high flow itself will cause irritation, and the chances of bleeding will start again, or maybe a collections of air over the sinus will be present. Now, relatively depend the benefit over the doubt. I mean, depend on the risk. How much of the risk if we use it, or how much benefit, even though if the risk present, it can benefit us. So depend on that situation, we can, in this relatively, we can use. In case of hypercarbia respiratory failure, this situation mean we can give it a trial. Like I say, if you have severe hypercarbia, if your PCO2 in the blood gas is so high, let's say is around 80, 90, that situation, obviously you have to use NIV or you have to intubate the patient. But if it is around 50, 60, you can still give a trial of, yes, you can still give a trial of high flow nasal cannula. But again, depend on the whether it's benefiting the patient or not, relatively. But in a situation, if we give like say for 5 minutes or maybe 10 minutes and see there is not much improve, so we better not use it for a long time. Okay. And in case of situation where hemodynamically instability. Now, for example, the patient who is in shock, if you know that the patient after some time, after you able to control through ionotropes or maybe through fluid bolus, you'll be able to control the child hemodynamically, make it stable, or maybe due to blood transfusion. So in that situation, if you think that within instantly you can control making hemodynamically stable, fine to use it. Or else if you think that it can take some time, it can be maybe severe shock is there, so better to avoid it in this situation. Okay. Facial anomalies, the same thing, maybe injuries over the nasal septum is there, or maybe injuries in nasal bridge is there, or maybe hypertrophy turbinate is there, or maybe one side deviated nasal, severe deviated nasal septum. In this facial anomalies or injuries, in this situation also you cannot use it. But if it is mild deviation and all, that is no harm. That is no harm to use the high flow nasal cannula. Okay. And then in a child, especially for us, like in pediatrics, for a child who are birth asphyxia, they usually have a lot of secretion. So excessive oral secretion will be there and nasal secretion. Now another situation in case of poisoning, all right, where a lot of secretion is there, and so in this situation, where there is excessive oral secretion or nasal secretion, now what happens is, in this situation, if you put high flow, the air will go inside the lung. Okay. After it goes inside the lung, it will push together with this secretion, and then it will reach your lung. So it will cause some much of then it will cause like the lungs will be covered with, will be full with your oral secretion or nasal secretion. Now, that is if it is a lot. Now the situation is if it is quite mild on nasal secretion, it's not much. Then in that problem, you can use it, no problem. With regular suction or oral suction, we can do it. Another situation is in bowel obstruction. Now, bowel obstruction can be due to paralytic ileus, or it can be any situation. Now, because why in bowel obstruction? In case of bowel obstruction, what happens is you put a high flow, the gas will keep on accumulating inside the stomach of the child. Now it does not get to pass down. All right. Now it does not get to pass down, and then that situation will keep on increasing the stomach volume, and then it will cause you much. It will cause you more problem in the sense that it will increase. It will push your diaphragm up, and then you will have more respiratory distress problem. Now, how we will use this? By if it is a small baby, we can use putting orogastric tube, okay, but not nasal gastric tube, not the Ralph's tube which we put from nasal cavity, because we are using for high flow. So from oronasal we can use it in that situation. Okay. Now another situation where we can use it or not, we cannot use it. Relatively, not hard to not use. Agitated or confusion. Mean a child who is fighting, who does not understand you, what you are trying to tell. Very irritating in case of CNS infection, or maybe in case of CNS trauma is there, or injury is there. So this type of child will be much more aggressive, and also you won't be able to keep all these things, all this nasal prong or the high flow nasal cannula, because they will try to pull off all these things. Now, the situation, it can be due to hypoxia. That's why the child develop agitation, okay, or maybe in case of CNS problem, or maybe due to hypercarbia, oxygen carbon dioxide level is too high, so that's why in that situation, like I said, so we better intubate the child and do invasive procedure. Okay. Now anyway, whatever the child who have a poor GCS, obviously we should not depend on high flow nasal cannula, because if we put on high flow nasal cannula, high chance that our child will end up intubated. Okay, so in poor GCS child, like we used to say, if it is less than 8, 7 like that, it's better to go for elective CS than to elective intubation than to go for change to NIV, change to this, because see the poor GCS patients sometimes they have breathing. You see that they are breathing nicely, but their effort is quite less. In a situation where they have to breathe, where their breathing is very shallow, So this type of situation will cause, if you look over a time period with this poor GCS, you will see that PCO2 is quite high. So if you would have seen in your ICU that there is a blood gas monitoring, especially in this poor GCS patient, because why? We, from our blood gas itself, we will understand that this poor GCS child is having effort is good or not. If POCO2 accommodation is present, then we understand that, okay, fine, the child is not having a good breathing effort, so it's better to intubate. Now, but if our GCS is, let's say, around 12 or 13 or 11, that child is still okay. I mean, he understands, still but confused or maybe disoriented, but his breathing effort will be fine. But GCS of less than 10, 9, 8, that less than 8 especially, to will better to intubate only, invasive procedure. Okay, this one I already explained you of. So those are the different way where we can use high flow nasal cannula, and in which situation we can use and how to judge. Okay, and the place where we definitely should not use high flow nasal cannula, I have mentioned you, and relatively contraindicated where we have to think the benefit and the risk associated if we use and if we don't use. Okay, now for example, in case of those relative, one more word on those previous slide. In case of this relative, now for example, you don't have, let's say, your doctors is busy with other patient, but the child required intubation. All right, I mean the child required intubation, like his GCS is 6 or maybe let's say 7, but you can still use this high flow nasal cannula, because it's easy to install, easy to use. It's not that you have to put so much of control or putting the input on the machine according to the patient weight, height, and then tidal volumes and all those things. It's quite easy to install. By the time, it will buy some time for the patient than to give a simple oxygen therapy. So high flow nasal cannula, what are the components we have? Okay, we have the flow meter, like I already.
Hello, no audio, no audio. Sir, you are not audible.
Hello. Sorry, actually we got disconnected. Please wait for a few more minutes. Bhuneshwar, am I audible?
Yes.
You can continue from here.
Okay.
Bhuneshwar, am I audible?
Yes, yes.
You and if we are audible, can you message me in the group? Yes or no? Sister Pranita, can you message me if you able to hear us? Can you message me in the group? Yes or no?
Yes, we can hear you. Hello.
Okay, yes. Okay. Wait a minute.
It is different, no?
Just
It's different. Different slide is not the same slide.
it's not the same thing.
Mhm.
It's not the same one.
No, where are we?
Yes,
Take-
yeah,
Okay.
it's same. Wait, let's go to the slides. This WhatsApp message will
Put it up.
Oh, okay. You are able to see our screen?
Yes.
Hello?
Yes.
It's good. Yes, okay. Thank you.
Okay, sorry for the interruption. So back, I hope you can see the slide. Okay, here what are the components I already mentioned to you before. See, here is a filter, okay. And here actually they didn't mention, they didn't show us another one where we have the okay. So here this one we have oxygen sources where we connect to the blender. Okay, this is also called a blender. This seems stable. This is the oxygen, okay, and then this is the flow meter. This flow meter means just how much flow we want. Okay, we'll be talking about how much flow for how much patient we will. Okay, so this flow meter is capable of giving a 60 liter per minute. Okay, this flow meter we have a capacity of giving up to 60 liter per minute. That is maximum for an adult. Okay, now the oxygen sources and the medical air sources will help us. Will connect to this blender, and then we will decide how much flow. The pressure will go there, will go toward the humidified machine here, humidifier, and then from the humidifier, then it will connect into the inspiratory circuit, and we will reach the nasal cannula. Okay. Now, again with this flow meter, near this flow meter, you will see that this we have the oxygen, how much to titrate accordingly. Okay. Like here, we can use FiO2 starting from 21% and up to 100% now, depending on how much our patient required to give oxygen. All right. Now, see, if you have to give even the flow of, let's say, 10 liters, so your oxygen therapy you can give up to 100%. Mean according to the required of the patient, not necessarily that you have less flow rate, but your FiO2 also should be less. No, it's not like that. It'll be irrespectively of the flow. Okay. Now humidifier is capable of fully humidify the inspired oxygen or air mixture at a temperature of 36 to 37. Okay. See, inspired air with this humidifier which we use. We will use to humidify the air. That's a mixture of this medical air and according to our saturation, according to our oxygen blender which we have titrated, and it will give us the same, almost the same heat of air that is with this humidified, not a dry air. See, that's why we use humidifier, because it will prevent our child from having this nasal crusting, and then upper airway irritability, dryness is there. So that's why we use humidifier. Okay. Heated humidifier. Now why we use heated? Because we want it to be the same temperature as what our body temperature is having, so that it will cause no irritability to our child, and it will improve. It will give more comfortness to what the child. Okay. So the heated tubing, it deliver the gas from the gas supply to the nasal without condensation. See, why is the without condensation mean? There is sometimes practically you might find a situation where there is a condensations of water is here, because why? Because it's like vapor air, no, evaporated air. But those we can clean. It's not a harm thing. Okay, we can clean that one. And this situation, this is the one with the heated tube. Okay, mean there's a wire connected for this this one, so that it will keep on monitoring the temperature from the start of the humidifier till there before it reaches the nasal cavity of the patient. Okay, wide-bore nasal cannula which convey the oxygen or the blended air from the gas tubing the patient nose. So, what are the benefit of high flow nasal cannula? So, the benefit which we get from high flow, like we already mentioned just now, is optimal humidity. Optimal humidity means it helps us in mucociliary clearance, like, because our nasal cavity is dry and in moist all the time. All right, so it will help our nasociliary clearance. Okay, now because of humidified air, there is no crusting, there is not dryness, and then the temperature is not cold air, not very hot air, as the same as our temperature. So we use it make us much more comfort. All right, now regarding flow benefit, we got it. Accurate oxygen delivery. Mean if we want to titrate our oxygen therapy, like for example 20%, 30%, 100%, or maybe 60%. So in that situation, we can use through this flow. this flow will give us adequate, mean that flow meter will give us adequate way of titrating oxygen. Okay, wash out the anatomical dead space. See, the anatomical dead space is the situation like a, the area where there is no exchanging of lungs, exchanging of air. Now, for example, our anatomical dead space is from the nasal cavity itself up to the bronchus. Okay, to the bifurcation of bifurcations of the trachea. Now, because since we see, if we have to breathe, the patient will have a resistance of nasal cavity, oropharynx, pharynx, larynx, trachea, and by the time it is, there is so much of resistance because it has to go through a small area. All right, and then this area also does not have any exchanging of air. So how do we wash out this anatomical dead space? Because there is a flow. We're using high flow, so there's a pressure which keeps on pushing the air in within, even though with our small effort of putting oxygen, it'll keep on pushing the air toward the lungs. So that's how it's help us in wash out the anatomical dead space. Okay, low level of PEEP. See, PEEP is the positive end airway pressure. Positive end airway pressure mean at the time of your end of air expiratory pressure. PEEP is so at the time of your expiratory, by the time you finish, that pressure which keep constantly building, that flow is much more less as comparatively like in case of CPAP, in case of BiPAP. Okay, and so in this type of in case of PSI, CPAP or BiPAP, the PEEP is quite high. We give 5, 6, 8. So in this situation, in case of that PEEP is much more or less as compared to the this non-invasive ventilations like in case of CPAP and BiPAP. So what are the physiological benefit which we got, which our patient can get from high flow nasal cannula? FiO2 value or higher and stable. Okay, so it will stabilize our FiO2. If we need to higher FiO2, or we like stable or constant FiO2, or how much saturation we need to target, we can easily it can easily maintain the patient. Okay, anatomical dead space is reduced. Okay, reduce the walk of breathing. All right, so the patient doesn't have to walk too much, does not have to put too much distress in walk of breathing. Gas deliver is humidified, which is normally also physiologically also the way we breathe at present is humidified. That's why we have sinus, so that all the air circulate in our sinus and in sinus first, and then it become heated and humidified and goes out, goes in. This is the same way. That's why we use humidified, heated, humidified high flow nasal cannula also to deliver like that. It provide a positive airway pressure. Mean all the time there's a positive pressure going, or positive pressure going inside the lungs, so that's why another way it's reduce the walk of breathing, and then try to open up the lungs. Okay, reduce the airway resistance in case of obstructive, in case of asthma, in case of COPD, those type of patients who have chronic obstruction, resistant or obstructions or mucus plug or anything during in their airway. So high flow, because of some pressure is there, some high flow is there, so it will reduce this airway pressure. But if it is too much of resistance or obstruction is present, like in case of asthma, severe asthma, moderate to severe asthma, so this will not help us. We might have to use, child is so much distress, we might have to use like CPAP or BiPAP. So initiation of therapy. Now when to start? We have to choose properly what patient we are choosing. Okay. I hope I am audible, or I am just a radio here.
I think you are audible. Let's send the message. Yes, sir.
Okay, thank you. I thought like I'm just saying something and nobody is listening, no? Nobody is hearing. Anyway, let's come back. So initiation of therapy means we have to choose appropriate. See, if we don't choose the correct patient, whether the child really our child really is suited for the high flow nasal cannula or not. Like we already know contraindication and relative contraindication, and also the indications of using this high flow nasal cannula. So first of all, whether the child have contraindication or not. If no, fine, good, go ahead. Whether in preparing the high flow nasal cannula, high likely that the patient will tolerate high flow nasal cannula. Okay, whether now, like I said in the other way, poor GCS child, agitated, confusion child, those are like anxious child, those two, they will not be benefit, because why? They'll be fighting and all. But if let's say grown-up child or stable child who is not confused, who listen to the mother, who listen to the doctors, who listens to the
Recording in progress.
Hello, Bunny.
Wait for me, no?
Hello, Bunishwar, can you please make Nanukatha as a host?
Yes,
got
done, done,
disconnected.
done. Please shake.
Okay. I'll try. Yes. And share.
It's okay, level like that.
Share up.
It's from here only, or
I'll stop.
from here, no?
Yes. Sorry, we also having a network issue.
Those who are from Meghalaya will understand the situation. Those who are outside of Meghalaya, so this is because of the load shedding. Okay. Anyway, generator is working. That's why we are taking time only in the arranging. Right.
It's
Where are we?
useful.
So we are talking about initiation of therapy. Okay. Yeah. So in this situation, like I said, we should know when to choose what type of child. So confusion, agitation, fighting child, not cooperating. So that type of situation is better not to give the child, because no point. We keep on fighting, pulling it out, putting it in. It will not help the patient. All right. So in this situation, it's better for us to go for the another way, which is much more comfort for the child. Simple oxygen therapy. Now, if it is GCS is poor, or maybe the situation is worsened, his respiratory distress is worsened, then we can maybe need to even to intubate. All right. But if our child is stable, calmly, not fighting, so better we will use high flow nasal cannula. All right. Now, the reasonable expectations that high flow nasal cannula will be adequate to stabilize or reverse the current respiratory status. Now, for example, now we will choose the child came to us who's in respiratory distress. Now, we will think, whether if we use high flow nasal cannula, it will help and benefit the patient, or maybe if we use high flow nasal cannula, it will instead keep the patient making more worse. Okay. Now, if it is a mild respiratory problem, mild to moderate respiratory problems, fine, we can use it, no harm. But if it is moderate to severe, it's better avoid use NIV or other type of maybe CPAP, maybe BiPAP, or in case situation where we have to use invasive ventilation. So depend on the situation of the condition of the child, which one to choose. Okay. Now, once you another important is setting is not a difficulty. Now, choosing the nasal cannula. For adult, yes, fine. You can say there's one range of adult. You can just give for adult. Okay. But in case of pediatrics, you should know, or maybe, in adult also, in a situation there where you should know that your nasal cannula, whether it is fixing approximately correct with the patient or not. How we will know it's fixing? Now, you see in this condition that your nasal cannula should be 50% cover. I mean, there should be space once you insert the nasal cannula inside the nasal cavity. It should not be fixed completely. Okay, it should not fix completely. So this type of situation, it will permit some leak and prevent the excessive airway pressure. If it is too tight and whatever pressure, whatever flow you keep, it will keep on pushing toward the patient's lungs. So in that situation, much excessive pressure it might goes inside. Okay. Now the distance between the prong will be wide enough to avoid pinching of the nose. Means situation that you should not have pinching of this nasal septum. A lot of situation by the time prolonged oxygen therapy, high flow nasal cannula or simple nasal cannula, that the child will have, pinching of this nasal septum, and it will be deformity. Now the gas sources, FiO2, like we already said, 21% or up to 100, or maybe 0.21 to 1, that is 21% to 100%. Flow, we can go 30 to 60 liter per minute. Okay, humidified is kept from 32 to 37 degrees. It's automatically, you don't have to adjust this one. FiO2 and flow, you have to adjust accordingly. All right, and humidified 100% with active humidifier. Nasal interface cannula is different size. Okay. Connecting in patient, you should explain the procedure, explain the procedure, how is it, even though the pressure is there, not to agitate. Okay, adjust the nasal prong, whether it is the nasal prong and the nasal cavity, it's covered completely 100%, like 100%, or some amount of leak is there so that the air can come out. All right, how do we will know how much flow we should set for the patient? It's 2 liter per kg per minute. So supposingly, if our child is a 10 kg, we will use 20 liter of flow. Now, and then it's a 2 liter per kg for a child who is at the first 10 kg. Now, if our child is 20 kg, that means we will add 0.5. So in this situation, 20 liter plus 0.5, another 10 mean around 25 liter we will be required for this, for this child. All right. And then, so maximum is up to 50. Even though I told you previously, the maximum level you can go is up to 60. But in our children, we will use up to 50 liter only. That also if it is children who are adolescent. All right. Now, if the positive pressure that is created inside, if the mouth is open, it drastically drops. All right. You see, when your mouth is closed, because whatever pressure is coming, it goes directly into your lung. But if your mouth is open, some of the pressure which goes and then it will come out through your mouth. Especially patient who receive NIV and a patient who have high flow, we used to tell them to better avoid, avoid talking during this when they are receiving this oxygen therapy. Okay, and then FiO2 we will titrate it and according to the desired arterial saturation. All right, just a second. Okay. And I want to carry this one. Okay, so this FiO2 will titrate it according to the arterial blood gas, or in another way we can titrate it by looking at the saturation. So how to titrate our oxygen? We will titrate it every 2 hours. You know, every 2 hours mean 5%. Let's say our child, we started with 60% FiO2, and then after 2 hours we check that as soon as we start 60% FiO2, even from the start till 2 hours, the child is maintaining saturation 98, 99, like that. So in that situation, we will titrate and reduce it every 2 hours by 5. Okay, so we'll go to 55, then 50, then 45. So these are the one which I just explained you just now, the whole thing, the whole procedure. Okay, this is high flow nasal cannula, which we use mostly in pediatric. All right, this is also we use in pediatric. This is some hospital have this type of system. It's the same only. You have the same mechanism. Gas sources. You have a blender. You have a flow meter. Okay, gas blender, flow meter. This is water, distilled water. Okay, and then humidifier machine. Okay, then this is all same only. And then you're connecting the then nasal that air tube, and then the nasal cannula. So this is the humidifier which we are talking about. Okay, this is both of them are the humidifier. So what we once we kept the patient in the high flow nasal cannula, what do we have to? We have to continuously monitoring the heart rate, respiratory rate, oxygen saturation, blood pressure, and mental status. Heart rate, because why? Heart rate will tell you whether the child is comfort or not comfort. All right. If the child is hypoxia, he will have tachycardia. If the child is comfort and lying nicely and maintaining saturation, his heart rate will come toward normalized. That is, rule out other shock condition. Okay, other septic shock or hypotension or whatever. Okay, we're just talking about respiratory problem. Now, oxygen saturation, if for the last 2 hours keep on maintaining, so we titrate it, taper it down. Blood pressure and mental status, because why blood pressure and mental status? This will tell you whether your patient is maintaining saturation, maintaining the carbon dioxide is not accumulating in the patient body, because if it is accumulated inside the patient, his mental status means carbon dioxide is more in the CN, it will reach the CNS and it will cause confusion, irritation to the patient, worsens of GCS. So that's why we have to keep on monitoring. Other things like periodic monitoring of cannula position or gastric distension, all right, and then blood gas, chest X-ray clinically indicated. So that is depend. If maintaining saturation, good chest and heart rate, so this chest X-ray you don't have to do round the clock. The most important is checking the nares and erosion or any secretion is present inside the nasal cavity. Tubing need to be checked to clear the rain out. Okay, especially like I told that evaporation which is there in the tube. So maybe collection of water will be there. Okay, if respiratory condition worsens or worsen in case of this situation, most common because we are delivering pressure. So check for situation of pneumothorax. Weaning criteria. When to take off from the high flow nasal cannula, or either you will go to simple oxygen therapy like oxygen, or you can just wean off directly from high flow nasal cannula also without giving oxygen if the child is maintaining with 21% FiO2. Stable heart rate, respiratory rate, SpO2 and blood pressure recorded over the last 24 hours. No evidence of any increased walk or breathing. Blood gas parameter within normal, especially PCO2 and PO2. And then weaning method means decrease FiO2 every 5% every hours to 40%. Like I mentioned you, like I told you, in every 2 hours before we mentioned. Once FiO2 stabilize at 40%, taper the flow to 2 liter. See, first of all, you have to target the FiO2 to taper down. Right? After you start to 2 liter per kg for the first 10 hours, sorry, for the first 10 kg and then 0.5 liter per kg addition for the next, more than 10 kg. That's how you calculate for the flow for the each child. So in this situation, we will titrate the flow by 2 liter per minute every 2 hours. So after we reaching our FiO2 40%, now it's time for us to touch the flow. We'll keep on reduce the flow rate. This flow rate will also reduce the pressure being delivered. Then we will shift, after that we will shift to nasal prong after stable vital on FiO2 with 40% and flow of 4 liter per minute. So the minimum is we will go up to 4 liter per minute. If the child is stable and maintaining heart rate, respiratory rate, SpO2 maintained, we will go to simple oxygen therapy, that is maybe nasal prong or face mask, depend on the child. Okay, so what are the components which to review? Nasal cannula, okay, whether heated breathing circuit tube, okay, air filter is present or not, and then unit cleaning, the whole system is the cleaning on it, unit keep it up. So this, how frequently we have to do? We have to renew, nasal cannula, we have to renew, give it, change each and every patient. Okay, how often? If it is a patient is requiring for 14-15 days, every 7 days we have to change it. Okay, in case of situation, this is what is written in the book. A situation like us, where money is a problem, then especially in government, so we cannot do that every frequently like that. Okay, and then that tube breathing every 14 days we have to change it, and filter each and every patient you have to change it. And how often, if same patient is using at least 3 months or 1,000 hours. Unit cleaning, this is to be done by the technician. I don't think you have to do much on that. Complication which we will have is abdominal distension, can be avoided by keeping nasogastric tube. Here, if we are putting high flow nasal cannula, we can use orogastric tube in case of a children, small baby, infant who doesn't have teeth. Pneumothorax, we can minimize by using the lowest effective flow rate. That's why we taper and titrate the flow once the child is having tolerating, maintaining saturation. Okay, and appropriate. I think I'm still on, right?
Yeah. Yes.
And then the inappropriate nasal cannula size to allow sufficient gas leak. Mean that, like we already explained, at 50% of that you should cover, and then the rest it should be out so that no excessive air pressure will reach the lungs. Trauma to the nasal mucosa. How to prevent it? By avoiding that the size, the width of the nasal cavity, nasal prong. Patient can be started on nasogastric or orogastric feeding after initiation on stabilization of high flow nasal cannula. It's not necessarily contraindicated to the child to be feeding in this situation, especially if the child is having orogastric. We can feed the child through orogastric, no problem. And after that, after 1 hour or to 1.5 hours, we can open the orogastric so that the excessive gas, if present in the stomach, also will come out. That's all. Thank you. Any question?
Yeah. Any questions you can write Any questions you can write down in chat box. You stop the screen sharing. Sorry, here is too much lightning and then
No network.
okay. Okay, we are seeing only thank you, sir. Thank you, sir. Any queries you have? Any question? How much flow rate can be started? Dr.
That's what
Desa?
we depend. The flow rate is depend on the child, you know. I mean, like, that's why we say 2 liter per kg. So we have to know the weight of the child and then started. Now, in case of adult, you can go directly with 40 liter. But in children, we go by liter per kg, 2 liter per kg in the first 10 kg, and then addition of 0.5 to another more than 10 kgs. First 10 kgs to 2 liter, and after that 0.5. I hope I'm clear for that.
I think you got the answers. Okay, you can scroll. Thank you for all your feedback. If anybody wants to talk, you can raise your hand. We will give access to talk. If anybody wants to share anything, otherwise we have given a post-test and feedback. Here also too much network problem is happening. Anybody have any queries? Let's see. Okay, thank you. Those who have submitted the post-test. And please, those who are asked, okay,
Can nasogastric feeding tube go along with
SFNC in place?
Yes, that's why I told you, in case of we would prefer this one orogastric in place of nasogastric, because nasogastric mean we are putting through the nasal cavity only. So in case of this situation, we will prefer orogastric, and then we will, so that we can feed the child.
I think
Because if you're seeing nasogastric and then with high flow, one of the nasal cavity will not be able to use the nasal cannula. So that's the reason we will prefer to go orogastric. And if it is adult, and most of the time they are in this situation, so we cannot put through mouth, so we better avoid. Or they can take orally. They can take orally in case of adult, but in infant we'll use orogastric.
I think Valerie, you got the answers. I think I've seen another question also. Can we use a nasal cannula for a newborn, or a nasal mask is better?
Nasal cannula or
Can we use a nasal cannula for newborn, or nasal max is better? Which one is?
see, depend. If I would have say there are each instrument has its own plus point, and each instrument has its own negative point. Now, for example, in nasal, depend on for how long you're going to use. That is also came into action. Now, if you use nasal cannula, use nasal cannula for like even quite some time, but if you maintain this, the gap, so hardly it will destroy or any cause trauma to the nasal septum. Okay, but in case the situation you use a nasal mask, like let's say for 1 week, 2 weeks, because newborn might require for quite some time. So you will see most of the time, the nasal bridge, it will get injured. Now, the same way, now nasal mask has the side effect on that nasal bridge will get injured, and then nasal septum, if you don't choose properly, we will have our nasal septum, nasal cannula will have our nasal septum affected because of the pinching. So preferably this nasal mask also, a lot of time when the child move, positioning of the child and all, when the child rotate or start to cry, or so that's why they'll be leaking. So preferably, I think it's better to go for a nasal septum. Nasal cannula.
Okay, so I think you got your answers. So next question
Which is the ideal site
to take the ABG in neonates. Though this is not the ABG class, you want to answer?
It's okay. See, normally, preferably we don't go for the peripheral vascular. Okay, not the distal one. So we prefer, if we really need for a neonate. Yeah, the question is for neonate, no?
Yes.
Okay, for a neonate, we will practically go. We will go like a venous blood gas, because it's much more easy for us to access. Number one. Number two, if we go for arterial in case of a children, we do in situation where we really want to know the partial pressure of oxygen or of carbon dioxide. So in that situation, we will use arterial, and in that situation we will preferably use the cubital one. than to go to radial. And why we don't use so frequently doing EBG in case of neonate, because they have very small arteries, and the chances of thrombus and then chances of a lot of traumatic will be there for the patient. So that's why we don't use, preferably we don't use it. We use venous blood gas, and if we do it, we use cubital, not femoral also, cubital only.
Thank you so much. We are getting so many thank you, and many of you are mentioning class was interesting and all. So you have any queries? It will be great. Every time in each sessions I ask, like, anyone wants to share your experience, because you all are working in a different hospital and you might have a very interesting stories which you want to share with us, and you will also get a chance to learn from you. We will be happy to hear from you as well. Even if you are not able to speak, also you can write down in the chat box, or those who want to speak, you can raise your hand, because I'm not seeing any questions out here. Thank you
That's all.
so much.
Sharon? Okay.
Okay. Thank you. And please don't ask post-test before class. We have not completed our class. So many people are asking a post-test. Okay.
Okay, that's all.
Yes, I think, thank you. We have not seen any more queries. So thank you so much. Thank you, Dr.
Okay.
Detar, for
Thank you.
wonderful sessions. Thank you all the participants. Be with.
Yes, definitely. We use it every day. Even to neonate also, we can use BiPAP and CPAP. But by CPAP, we preferably use CPAP in case of neonate, infant, and then BiPAP in older children.
Okay, what is the difference between BiPAP and CPAP they are saying? Anyway, we are going to take class separately.
Yeah, there's a separate class for this. Okay, that I will not answer.
We have a separate class for this mechanical ventilations. Okay, thank you so much. Don't forget to ask some questions during that sessions. Okay. It is necessary to give only by distilled water, or can it be substitute?
Preferably we'll go to distilled water, because maybe NS we can use, but crystallization will be formed, no? So that's why we don't prefer other. But if we don't get an option, we can use NS. But if we get an option, we will use distill only.
That's
And
it. They will say only distilled water, but otherwise, because again the machines will get this thing.
crusting and crystalline,
Yes,
crystalline will be formed.
Machines will get damaged. I will share you the video also, because because of the network issue, we are not able to show you video. But definitely, I am going to share you how to use this SFNC. That is for adult, but the principle is same. I'll share you in the WhatsApp group. Okay. Okay. I think if there is no more questions, then we'll stop the sessions. Thank you, everyone. We will
Okay,
see you
thank you so
tomorrow.
much.